Good afternoon, everyone. I'll be discussing preoperative evaluation in pediatric cataract eyes. Uh, so, the first step, as the parents come with the child, they are worried, they are anxious, they want to know the prognosis, they want to know from you whether you can implant an IOL, what will be the rehabilitation course. They are worried. So, first thing, you need to calm them down, ask a detailed history from them about their antenatal period, their prenatal period, any drugs, any illnesses, any rashes on the body, and if a patient has a history of trauma after the birth, these all things are important. Detailed history, how the trauma, and if there are any open globe injury, closed globe injury should be evaluated and asked for. Second thing is to assess the visual acuity. This not only helps in giving prognosis to the parents, but it also helps in how to rehabilitate the patient. Then third step would be systemic evaluation. Since most of the bilateral cataract or few of them are associated with systemic association, any illnesses, so we need to evaluate. Fourth is the ocular examination. In pediatrics, you can't make him sit on the slit lamp and examine the eye. So we need to take a different course to examine the eye. And fifth is the biometry, which is done on the table in, under anesthesia. So what are the complaints which with parents come for? They come with a complaint of whitish reflex noted by the grandmother or aunt or the mother herself while feeding the child. Then there might be few children who are rubbing their eyes. This is ocular digital phenomenon. Then few patients, like in this one, the child squeezes the eye on the eye in the same side with cataract, and there is spasm of the face on this side. This child is also photophobic. Few parents notice abnormal ocular movements in the child, and then they report to an ophthalmologist. In this eye, it was difficult for parents to notice, but at the age of 1 year, they noticed that there is difference in the size of the two eyes, and on further evaluation and on in the OR, we found that the child had PFV in the left eye. The causes of the leukocoria can be anterior or within the lens matter or posterior to the lens. Anterior, it can be due to the cornea or anterior segment dysgenesis, and posterior to the lens, it can be retinal detachment, toxocara, persistent fetal vasculature. Now, to assess the prognosis, to give prognosis to the patient, we need to assess the fixation, especially in child with congenital cataract. So it may or may not be central, steady, and maintained. These three things are most important. Central suggests a foveal fixation. Steady means child does not have abnormal wandering movements or nystagmus. And if there is a media opacity for a long duration, child might have developed strabismus, due to which there is, he or she does not maintain the fixation. Visual acuity assessment can be done by the tellers or OKN drum or a Catford drum in pre-verbal children, in toddlers or infants. In 1 to 2 years of age group, we can go for Cardiff, which is based on vanishing optotype. 2 black lines separated by a white band, and which can only be visualized at a particular distance or lesser, and then it gives a better idea of visual acuity. Then ivory marble ball test. Then you have Steiker for retards and young children. Miniature toy test, where on screen the same toy is shown in a bigger size and the child has to pick up the toy of the small. Then coin test, and then you have Lear symbols. In 3 to 5 years of age group, Allen card test, HOTV, these are the first letters which child can identify. In more than 5 years, Snellen's, Landot C, and tumbling E chart. How to examine a child? That's the most important thing, because child is anxious, and there is a inbuilt white coat syndrome because he has received all his vaccinations at this age group. So the best position if the child has developed neck holding is the shoulder hold. The child has maximum contact with the mother and child feels comfortable and shows easily. For those 1 month, few weeks old, it's better to hold the child in mother's lap and then examine. Any abnormal facies, head circumference should be noted at this point because one might suspect congenital rubella syndrome or any syndromic association. In cases of unilateral cataract, pupillary response become essential since it might be a RD, it might be a PFV, and prognosis might be grim, which we need to determine before we go into the eye. Distant direct examination and dilated pupil examination are important. This patient came to us with bilateral aphakia. Now, when we dilated the patient, the lens, microspheric lens, came anterior and it can be seen dangling in the anterior chamber. Now, these children need to be made stable to undergo the surgery. So, systemic evaluation, if any history of seizures, then neurological consultations and anti-seizure medications. In cases of uveitic cataract, which we are receiving these days in a large number, one must start biologicals or methotrexate or MMCs. Then for the galactosemic patients, one has to go for urine and blood sugars. These are few syndromes which we have picked up at our center. Alagille syndrome, broad nasal bridge with epicanthus palpebralis, moderate hypertelorism, butterfly-shaped vertebra, lamellar cataract, Larsen syndrome, which is inbuilt deficiency of collagen 7 synthesis, has patchy alopecia, syndactyly, polydactyly. Then this one with fetal valproate syndrome has anteverted nares, broad forehead, telecanthus, flat upper lip and thick lower lip, and inguinal hernias. Sickle syndrome, X-linked hypophosphatemic rickets, and trichothyroid dystrophy recently picked up with a tiger trail appearance of a hair shaft on polar trichoscopy. Now, to examine the child on the table, the first step is to do the axial length and the corneal diameters because it allows us whether to determine whether we are going to put an implant or not. So, if we take a cutoff, if corneal diameters are less than 9 and axial length less than 17, then we might not put an implant. But in eyes, in unilateral cataract, we might go at borderline values. Second is the keratometry assessment. Handheld keratometers can be easily used to assess the keratometry. IOP assessment becomes essential in uveitic cataract as well as rubella-induced cataract, micro-ophthalmic eyes to rule out glaucoma at this point. Angle assessment becomes essential in cases of blunt trauma where there might be a chance of cyclodialysis, iridodialysis, which is missed on pre-op evaluation, which can be easily assessed by Swan-Jacob gonioscopic lens. UBM is must and it helps a lot in most of our cases, especially in cases with posterior capsular defect with persistent fetal vasculature. These cases can be easily picked up and the surgeon can make up his mind how to approach the case before even going into the eye. These are few photos which we have picked over time. Ultrasound biomicroscopy will be discussed by Dr. Amar in next. IOL estimation has to be will be discussed by Professor Coker. Thank you.